Hi, I'm Elise Riley, and I'm a health disparities researcher at the University of California, San Francisco. I'm joined today by colleagues from UCSF and colleagues from University of Washington to share our experiences and ideas for implementing low barrier HIV care. Now, if you're watching this, you probably already have a sense of why low barrier care is so important. But let me say that patients with unmet medical and social needs face a lot of challenges when it comes to receiving traditional care. And this is especially true for patients experiencing homelessness or unstable housing. But the Max Clinic in Seattle and the pop-up clinic in San Francisco have been trying new models of care and approaches that focus on some of the social and structural issues that make getting needed care and adhering to medications so challenging. In the next hour, we'll share lessons we've learned in the process of implementing and studying these models of low barrier care. And these are disclosures for our group. In terms of what we'll cover today, I'll give a brief overview and talk about some of the issues facing patients. Then Julie Dombrowski will introduce us to a low barrier care model and share an implementation framework. Then Elizabeth Imbert will talk about San Francisco's pop-up clinic at Ward 86 as an example of low barrier care. Then Meena Ramchandani will go on to provide insights from another low barrier care model, the Seattle Max Clinic. And finally, Matt Hickey will wrap up with lessons learned. Our hope is that you can take away some ideas for your team or your clinic as you care for people with complex medical and social needs. So what brought us to focus on low barrier care? Well, advances in HIV medicine have cut new infections in half and reduced mortality among people living with HIV by 70% and dramatically improved their quality of life. However, in parallel, we're still seeing 35,000 new cases every year in the US alone. And when we look at the continuum of care, it's clear we're not yet reaching 90-90-90 goals. And the thing this graph doesn't show is the disparity in terms of who is diagnosed, who receives care, and who is achieving viral suppression. Advances in HIV medicine are not experienced equally across individuals living in the US. Instead, specific groups have specific challenges that have led to a collection of what's referred to as microepidemics. Among people of color, those living in southern states, men who have sex with men, and people who face financial hardships and unmet social needs, particularly people who experience homelessness and housing instability. Clinic-based studies and community-based studies consistently show that people who experience homelessness or housing instability have worse outcomes at every stage of the HIV care continuum. And this isn't surprising, because access to healthcare isn't simple. It rests on a multitude of interrelated conditions, including predisposing factors like housing and food insecurity, enabling factors like income and insurance status, need factors, which represent health status, and health services use, not just HIV care, but all types of care that are needed for patients who have complex needs. So in the context of HIV care, in places like San Francisco and Seattle, where people who experience homelessness and housing instability disproportionately represent new infections and disproportionately represent poor outcomes among people with HIV, it's clear that we need to offer different ways of receiving care. And with that, I'll pass it on to Julie Dombrowski, who will talk about low barrier care models. Thanks.
Thank you, Elise. Low barrier care is one intervention situated within the spectrum of differentiated service delivery, or DSD, for HIV. And this strategy is really simply the concept of adapting services to the needs of patients. As shown in this logo recently presented by HIV-MA, it includes ratcheting up or down both the touch points within the healthcare system and the interventions offered based on patient need and preference. In the global context, DSD has primarily been studied to reduce burden on the healthcare system and de-intensify services for stable patients. Whereas in the US, the primary focus of DSD to date has been on intensifying services for people with complex needs. Next slide, please. So the goal really is to have a spectrum of care services tailored for the local context, which runs from lower support, less intensive services, all the way to the higher support services, of which low barrier care is one. Next slide, please. The definition of low barrier care that we're using here today is a care model designed to engage people with HIV who are not engaged in medical care as it is conventionally organized. And this model provides primary care, including HIV care, for a defined cohort of patients. Next slide, please. Great, let's talk about the intervention elements as we've conceived them. Next slide. So I'm separating here the structural elements of low barrier care, what it is, from the process elements of low barrier care, which is really how it's done. And the structural elements include walk-in access to care, integrated high-intensity case management, and incentives. I've put an asterisk here because there's at least one example now of low barrier care, evidence-based improvement for, with evidence showing improved engagement in care that does not utilize incentives. And the process elements are a low barrier care philosophy, cross-agency collaboration, and commitment to rapid modification. Next slide, please. Great, well, what do we mean when we say these? Walk-in access to care is really drop-in primary care, again, for a defined cohort of patients. In a typical HIV clinic in the US, we often have walk-in access for urgent care services and triage, but less commonly really provide primary care and ongoing services through that model. This is one of the most challenging things to do administratively, but one of the simplest and most important elements in terms of low barrier care. The second is integrated high-intensity case management. And what I mean by this is really co-located case managers working as a team with the medical providers so that we are addressing social needs as a central part of medical care. And incentives really can come in many different forms, but the idea is providing something extra that is a tangible reward to patients for engaging in care and helps address immediate needs, such as food or clothing, or other things. Next slide, please. The process elements, low barrier care philosophy. So I think in all of our HIV practices, we strive to provide client-centered or patient-centered care. Low barrier care philosophy is certainly patient-centered, but goes a bit beyond the model that we often use in providing primary care. It really requires adapting the care goals to the patient priorities, and not just their priorities, but their abilities. What is feasible for that individual patient? And sometimes that involves radically streamlining medications, really to focus on one or two, and creative care plans, especially when patients may have a problem that would be better addressed in the hospital or emergency room, but aren't willing to go there. Cross-agency collaboration is something, again, I think we often do in our main clinics, but this requires even more intensive time, especially on the part of case managers, to talk with people in other agencies who are interfacing with the same patient population. So working closely with our contacts and colleagues in jail release planning, housing, methadone clinics, and mental health treatment programs in particular. And then, of course, the commitment to rapid modification. The idea is really to pilot, to start small, to learn fast, and to iteratively improve over time. And I think this kind of strategy is really crucial to get going and build up. And you do need to be quick to abandon the things that don't work and try something new. Next slide, please. All right, implementation considerations. Next slide. Adapting this model to the local context is really crucial. And of course, especially even within the US, we have variation in our HIV epidemiology between different geographic areas, differences in barriers to care and the prevalence of specific barriers, resources available to address HIV care and prevention, the social context, and policies and laws. So all of this varies quite a bit, but I do think the central idea of low barrier care, which is really adapting the healthcare system to reach the highest need people with HIV, is broadly relevant. Next slide, please. So we put forth a framework for low barrier care implementation based on our experience and really looking back at the lessons learned over time and how we would recommend thinking about this. These can be done in parallel and they don't necessarily need to be done sequentially, but each are, I think, important. I'm going to briefly introduce this model and then you'll hear more about the Max Clinic and the pop-up clinic and how specifically they addressed these different steps. So this is based on the EPIS model, an implementation science framework, exploration, preparation, implementation, and sustainment. And in the exploration phase, you can see here is really about defining patient population, estimating population size, pardon me. And the other ones I'm not going to talk more about because you're going to hear about them in just a moment. So thank you very much, and I'll pass it over to the next speaker.
Thank you so much, Julie. So my name is Liz Imbert. I am a physician at Ward 86, which is the HIV clinic at San Francisco General Hospital in San Francisco. And I'm going to share about our program Pop-Up, which was the care model that we designed to engage folks living with HIV who experience homelessness or unstable housing, and usual care was not working for them. So when we were starting with defining our target population and estimating our population size, we began by surveying folks in our clinic. And on the left, you'll see a bar graph that shows housing status, and on the y-axis is viral suppression. And what we saw is there was a dose-response relationship between viral suppression and housing status, with the highest mean viral load being in folks who are living outdoors. We also saw, if you took these different groups and looked at folks who were stably housed, temporarily housed, or unstably housed, that folks who were homeless had much higher rates of utilizing urgent care services, urgent care, the emergency room, and hospitalization. And so we know that housing is really essential, and really there's good evidence to show that housing improves HIV outcomes. However, we know that we do not have enough affordable housing for folks who are homeless or unstably housed at this time. And so we were really at this point of thinking, how do we create a care model now to address the disparities that we're seeing. So our pop-up program initially focused on folks who were homeless or unstably housed in our clinic, who were virally unsuppressed or reported being off ART. And we initially focused in on folks who had difficulty engaging with traditional primary care. So they had to have missed one primary care visit in the last year and dropped into our clinic twice in the last year. We've more recently in the past few months changed this criteria and omitted the engagement piece, particularly because we now have a mobile capability in our program that we didn't have at first when we were initially trying to just make the clinic as low barrier as possible. So folks are referred to our program through our nurse. Folks send a referral request through our electronic health record. And in particular, if folks do not link to us within 2 weeks, then we send our mobile team out to them to see if they're interested in engaging with our program. So our pop-up clinic is situated within Ward 86, which is the HIV clinic at San Francisco General. And some key collaborations and partners that we had from the beginning were the Alliance Health Project at UCSF. And they really gave us embedded psychiatric consultation, which has really empowered our primary care providers to treat and manage mental health disorders. And another key partner has been the Department of Public Health that's assisted our team with navigation support, as well as really being a key collaborator when folks are incarcerated. So in terms of preparation and a buy-in plan, our division chief, Dr. Habler, and our medical director, Monica Gandhi, really spearheaded these efforts to change our model of care for folks who were experiencing homelessness or unstable housing. And this is just a flyer here when we launched our program, and we had key stakeholders from the hospital, from the Department of Public Health, political officials, to really rally around doing something different for our folks who are homeless or unstably housed and living with HIV. So to talk about our program and harken back to the different elements of the intervention, the structural elements that we have, so we're a drop-in program, so patients can come in any afternoon 1 to 5, Monday through Friday, but we really try to do full scope comprehensive primary care during those visits. So we have social workers on the team that are dealing with subsistence need, behavioral health interventions. We have an addiction medicine doctor embedded into our team that's assisting us to treat substance use disorders. I mentioned our psychiatrist, and then we have nursing support as well as pharmacy support and pharmacy tech support, which has been particularly key in the folks that we've started on long-acting injectables who are in our program. We do have an integrated care team, so it's really a comprehensive multidisciplinary team that's working together, really bringing all our expertise together to develop care plans for patients. And then we have incentivized care, so folks get grocery gift cards for coming to clinic and seeing a provider, for getting labs drawn, and if they achieve an undetectable viral load. The low barrier care philosophy is really key. When we meet folks, we really ask them what they want to work on, what's important to them, what they want to partner with us on. But then we also think as a multidisciplinary team about what are the key barriers to successful care, whether that be substance use, housing, mental health disorders, and then try to systematically come up with a plan with the patient to try to address some of those things that are getting in the way or not allowing them to achieve the health status that they want to achieve. The cross agency of collaboration is really important. Folks touch many touch points, the jail, the hospital, the emergency room, various community-based organizations. So really having collaboration with different organizations and different entities is really key in coming up with individualized care plans. And then the commitment to rapid modification, I think when we launched in 2019, that program looks very different than our program now. And so just really learning and seeing what's working, keep doing that. But if it's not working, being willing to reinvent the wheel. So in terms of written procedures and data systems, we have a behavioral policy which essentially says, what we expect from patients and what they should expect from us. And it has clear outlines of what behaviors or actions are not acceptable in the clinic setting and the response that we will have in those settings. We have developed a patient contract. So when people enroll in our program, we review this with them and have them sign, and really is a signal that we're entering into a partnership where we want to be respected and they want to be respected. We do have a policy around our incentives, about the maximum incentives you can have. And then in terms of data systems, so data systems that we have developed have been really key in following our cohort and executing on panel management. So in terms of what's in the electronic health record, we have, and I showed a picture here, we have various lists where we keep track of who's eligible, ineligible for our program. So when they come into clinic, we can do a quick look and say, oh, they've been eligible. And then, as I said, if they don't show up in 2 weeks, then our mobile team is going out to try to engage those folks. We have graduated a few people from our program, and so we keep a list of those folks as well as those who refused to engage with us. We also have a weekly case conference where every team member joins for an hour and a half once a week. We use an Excel file that is pre-populated with visit data and viral load data to systematically review patients. And so for the first 40 minutes, we talk about patients alphabetically, and we say, are there any medical issues or any social work issues? We try to keep it really simple, but that is really where we come together, get the expertise from everyone in the room to come up with individualized care plans. And then we have dedicated meetings to review our folks on long acting, any folks who are candidates for graduations, any folks who may need escalation to mobile care. So not dropping in and we need to go out and see them. And then one key thing for staff training and support has been a therapist who does quarterly facilitation with our group to process vicarious trauma and compassion fatigue. And that's been a really supportive space for our team. So in terms of giving an example on how we do sort of iterative improvement. I'll share a little bit about some of our outcomes. So if we between 2019 and 2021, we enrolled 112 patients. More than half were street homeless, 100% had a substance use disorder, and 70% had a mental health diagnosis. And as you can see on the bar graph, this is the proportion with visit in each 3-month period, and about 70% had a visit in all 3 of these 4-month periods. However, when you look at the timing of folks' visits, 59% had at least one 90-day gap in care. And when we had looked at this data, this was prior to us having a mobile intervention. And so this really motivated us to say, okay, we've tried to make the clinic setting as low barrier as possible, but folks are having quite long gaps in care, too long. And so we started our mobile pilot, which is now fully part of our program. And there's a picture of our social worker and our medical student who is working with him there. But we go out and we do mobile outreach to folks who are very remic and we haven't seen in 30 days or haven't seen us in 180 days, or the clinic team has a medical reason for them and that we know their location in San Francisco. And this visit is really focused on building the relationship, saying, you know, we haven't seen you in a while, what's going on? Are there any barriers to them coming in or adherence to their medications? And then before our team goes out, we do a review to see if they're eligible for long-acting injectables and share that with the patient, that we have a new medication and they may be interested in that. And then we also do housing and income support during that visit. So to look at our overall outcomes of our program, the PAPA program, we've ever enrolled 211 patients. We're currently following 146 patients. Our current viral suppression is 73%. And just to remind you, everyone in our program either was unsuppressed or off ART when they started. We have about 23% of our cohort that is on long-acting antiretrovirals. 60 of those 146 folks have received some sort of mobile outreach from our program. We have quite a high mortality, so about 13% of our folks have passed away, and the highest proportion is from substance use related. And then we've had 23 folks transfer out. Of the people who are currently enrolled, you can see it's a diverse population. We see about 40% street homeless folks and high rates of methamphetamine use and mental health disorders. And so at this point, I'll pass it on to Meena, who's going to talk about the Max Clinic and another example of a low barrier care model.
Thanks, Liz. Hi, everyone. My name is Meena Ramchandani, and I'm going to describe some key features of the Max Clinic, which is a low barrier clinic in Seattle. Next slide. So the Max Clinic was developed after reviewing the response to 2 other projects that were not successful in engaging persons with HIV who were out of care in the Seattle and King County area. And what we found is that relinking individuals to the same system of care, which is usually the traditional medical clinic care model, which is appointment-based, was just not an effective strategy for these particular individuals. They were out of care, and so linking them back to the same system which they had disengaged from in the first place didn't really work. And so there was a shift from trying to change patient factors to changing the system or clinic model to improve engagement. And this is where the idea of the Max Clinic was first developed. The original approach was small, with the idea that we would adapt and then learn as we grew. So what I'm about to present might seem organized and very comprehensive, but in reality, it was just sometimes through trial and error. And adaptation is key. But we did have information from those original projects on what might be helpful when designing a new program for these individuals with HIV who are out of care in the Seattle and King County area. Next slide. First, we had to identify the high priority population that we wanted to enroll. And I think something to note is that Seattle has resources already for excellent wraparound HIV care, but there were individuals who couldn't link to that system. And so based on that previous data, we found that the patient criteria of virally unsuppressed or off of ART and not engaged in care out of multiple outreach attempts or newly diagnosed and unhoused would identify the population that we were hoping to engage for the Max Clinic. It's a very high intensity intervention, both in resources, excuse me, both in resources and time for a relatively small group of persons with HIV comparatively. and with the estimate population size in Seattle and King County of about 800 individuals. Next slide. So the Max Clinic is jointly operated by the local health department, which is Public Health Seattle and King County, and an academic affiliated county hospital, which is Harborview Medical Center. And it's affiliated with the University of Washington with support from the State Health Department in Washington. It's located within the Seattle and King County Sexual Health Clinic, which is on the Harborview Medical Campus. And a key partner is the Madison Clinic. The Madison Clinic is a comprehensive HIV primary care clinic with on-site medical case management and a pharmacy. And it's located in a separate building across the street as the Max Clinic, but on the same medical center campus, which is Harborview Medical Center. Next slide. When thinking about the Max Clinic, there are advantages and disadvantages of co-location within another clinic. And so I'm going to share some of those advantages and disadvantages here on the slide. The Max Clinic, like I said, is located within the Public Health Seattle and King County Sexual Health Clinic on the Harborview Medical Center campus and across the street from the Madison Clinic. So the advantages of co-location is the sharing of resources. For example, front desk, waiting rooms, sexual health care, and range of services that the Sexual Health Clinic provides for its clients can also provide for Max Clinic. And there's support for the staff being part of a larger clinic, especially when the low barrier clinic is starting out small, can be really helpful for staff support. The close proximity to a hospital we found to be very helpful, especially in the setting that many of these persons with HIV hadn't engaged in the medical care system for so long, and so might have other comorbid conditions or opportunistic infections where close proximity to a hospital was very important. For example, access to a lab, to radiology, or the emergency department, especially when thinking about that primary medical care. And then medical support through other specialty clinics was also helpful. It's nice to be on a medical center campus where you can access ENT or dermatology or cardiology. And then there was huge support through Madison Clinic, through the primary traditional HIV clinic at Harborview Medical Center. And that support came through social work, nursing, pharmacy support, and they also have specialty care support for persons with HIV. There's also opportunities for collaboration with the co-location that I think is an advantage. And the MDs that were providing care in the Max Clinic are also affiliated with the Sexual Health Clinic. So being that co-located space was very convenient for the medical providers in the Max Clinic. Disadvantage of a co-location is can be space for the clinic, the low barrier clinic, but then also space for the original clinic that you guys are co-locating within. Because both clinics are going to expand over time and want to grow, and they're competing for space. And then there's impact of the patient on the patients of the original clinic and impact on the staff of the original clinic because the patient populations might not be the same. And so navigating the impact will be something that I think has to be taken into consideration in terms of that co-location space. Next slide. When we first started this, the Max Clinic, this is what the Max Clinic model originally looked like. The patient was provided support through MD support, the public health DIS, and DIS stands for Disease Intervention Specialists, which are frontline public health workers. And they really acted as outreach support and non-medical case management support. And then also social workers that provided medical case management support. Originally, the social workers were through the Madison Clinic, the HIV clinic that I was telling you on Harborview Medical Center, until we were able to have dedicated Max Clinic social workers. Next slide. So the Max Clinic model had some of these key features. We had walk-in access to primary medical care, including HIV care, integrated high-intensity case management, and then incentives. And these are what our incentives look like. So we had cash for visits with a lab draw every 2 months, and that was $25. And then if patients met viral suppression, a viral load of less than 200, they would get an extra $50 at that time every 2 months. They had grocery vouchers they could get every 2 weeks. Originally, these were meal vouchers, but then we switched over to grocery vouchers. And they could get snacks at each visit. and they were unlimited. Patients also had access to unrestricted bus passes, and then over time, we were able to also provide clothing, hygiene items, and makeup kits. Next slide. Other features of Max Clinic model is that whole idea of a low threshold care with this harm reduction approach, and that harm reduction approach comes from multidisciplinary team members. Patients had access to medical care walk-in. Originally, when we started, this was only in the afternoons, Monday through Friday. But over time, as we were able to add more medical care support, we expanded to have morning availability for medical providers as well. But during the entire time from the clinic, patients had access to walk-in support for the case managers, both morning and afternoons, 5 days a week. They have direct phone line to the Max staff with no phone fee needed. So they were able to directly contact the Max staff through text message or through phones. And then also they were able to get high intensity outreach support from both the non-medical case managers as well as the medical case managers. Other features of the Max Clinic model that I think are important to discuss are the coordinated care and case management that happened with other community partners throughout the Seattle and King County area. And we realized that the Max Clinic patients were interacting with different community partners, or different community partners were looking for the same individuals. And so coordinated care was really important and a big feature of engaging these patients and providing that wraparound services. And so you can see here some list of some of the coordinated care that we did with jails, with case management, both in housing, with mental health support, and other community programs. Next slide. Funding was provided through a variety of resources, as you can see from this list below. I'm not going to go through too much in details, but you can see Washington State has provided quite a bit of the funding. There's also funding through Ryan White Part B programs, through Medicaid, and then through ADAP, which is the AIDS Drug Assistance Program, and other funding resources, including ending the HIV epidemic. And the Max Clinic incentives are provided to patients by health department staff using public health funds that do not come from federal resources. Next slide. This is a busy slide, but I think I just want to impart that there was an evolution of the Max Clinic over time. I think sometimes it can be daunting in terms of starting a low barrier clinic and thinking about all the resources that might be needed. But when we started the Max Clinic, we really only had 3 medical providers providing care just in the afternoons, Monday through Friday. And we only originally started with 1 non-medical case manager. Over time, we were able to grow to meet the patients that were enrolling in the program. And we eventually had medical case managers that were dedicated to the Max Clinic, able to expand to more non-medical case managers and be able to provide medical care in the mornings as well. Over time, we also added a nurse as well as a mental health practitioner and consulting psychiatrist. And over time, as you can see here on the bottom, we improved collaborations with outside organizations. I think the take-home points is that the clinic evolved over time and the staff evolved over time. And so when thinking about that low barrier care model, just kind of using what you have can engage a number of patients. And then as your clinic grows and you're able to provide more resources, then you can grow in terms of your medical provision as well. Next slide. So I think some of the questions come from in the Max Clinic, how did we get patients to enroll in our program? And then how do we accept patients into the Max Clinic? So providers, community partners might have different expectations or understandings of what out of care might mean. And this is what we realized. And so we realized we needed to organize our criteria to enroll our high priority population, communicate effectively with other providers and community partners in a way that they can understand who's going to be accepted into the Max Clinic, do they meet criteria, who's not accepted and why, and then also provide flexibility when flexibility is needed. And so when thinking about where are these patients and how do we find these patients who might meet the Max criteria, having public health as a partnership was a huge, I think, success in our program. because we could integrate the clinic with HIV surveillance data. And there were already public health programs to identify, trace, and contact out-of-care persons with HIV. And so when public health programs identified a patient who might be eligible for Max Clinic, they could then make a referral into the Max Clinic, which was a great way to connect persons with HIV who are out of care into the Max Clinic. Referrals came from providers and medical clinics as well, originally first at Madison Clinic, which was our main partner. And then as Max Clinic became more, I think more community partners became more aware of the Max Clinic, referrals also came from other clinic providers, other hospitals, emergency room staff, and other community organizations. And so in terms of how to decide a patient is a Max Clinic patient or not, we developed a multidisciplinary review of referrals to decide on, does this patient meet criteria? And then if they do, we'd accept them into the Max Clinic. How do we effectively communicate to those community partners or to those clinics or those providers that the patient's been accepted into the Max Clinic? How do we also communicate if a patient doesn't meet criteria and is not accepted? And then for a couple of individuals, we realized there are patients who didn't meet criteria, but may have had a social situation that we could foresee not that we could foresee, actually that's incorrect, that could potentially, they might meet Max Clinic criteria in the future. And so we would have them on a watch list for public health to kind of evaluate if those patients would need Max Clinic in the future or were able to engage in the medical care that they were getting. I think the key thing is that you always need flexibility to decide on a case-by-case basis. And so you can have written criteria to provide guidelines, but written criteria can't cover every situation. And so flexibility is important and adaptability is important as well. Next slide. Over time, we have grown. And so not only in the size of patients enrolled, I think we're about 375 patients that we've enrolled in the Max Clinic, but also in the care we are able to provide as the clinic expands. And as you can see here, this is all the providers that surround the patient and provide that wraparound care in the Max Clinic right now. Next slide. In terms of our evaluation, this table shows the patient population and the characteristics of the patients enrolled in the Max Clinic. We started in 2015 up to, this was analyzed in April of 2023, where we had 357 patients. And as you can see here, 74% are cisgender male, 21% cisgender female, 3.6% transgender or gender diverse. 5% are American Indian or Alaska Native, 2% Asian, 25% Black, 9% Hispanic or Latinx, and 1% Native American or Pacific Islander, and 51% are white. The mean age is 40. Next slide. Most patients used illicit drugs or hazardous levels of alcohol and had diagnosed psychiatric illnesses and unstable housing. At the time of enrollment, 97% had unstable housing, substance use, or mental health disorders, and 42% had all three factors. Next slide. So this figure shows an analysis of the first 50 Max Clinic patients enrolled between December 2014 and November 2015 and the impact on viral suppression. The control population for this study includes Madison Clinic patients who were identified retrospectively who met eligibility for Max Clinic enrollment but did not enroll. And the percentages for patients in each group who achieved each outcome in the 12 months pre-baseline and post-baseline are shown in the figure. In the year after enrollment, 82% of Max Clinic patients and 65% of patients in the standard of care control group achieved viral suppression. What we found is that the 50 Max Clinic patients, 44% reached and maintained a continuous viral suppression. The majority of Max patients engaged in care in the year after enrollment, and it was significantly higher than pre-baseline engagement, and that was 82% compared to 44%. In a subsequent analysis in 2016, during the year after enrollment, what we found is that 95% of patients engaged in care, and at the end of 2016, 80% had achieved viral suppression at least once, and 54% had continuous viral suppression. So a success in my mind. Next slide. We also conducted qualitative research to understand patients' views of the clinic and which of the components were most essential. And the key theme that came up when patients were asked open-ended questions about the Max Clinic is how the patients feel they are treated at the clinic and how their social circumstances are recognized and addressed. They found that this was a big positive thing about the Max Clinic. In terms of asking questions about incentives, there was really heterogeneity on the importance of incentives, with some patients saying that they were crucial and a key thing that got them out in the door. And then others saying the incentives weren't really important to them. And I think the general theme, what we found is that the incentives can be a bridge to engagement, but aren't enough in and themselves to become, and they become less important over time. Next slide. So thank you for listening. I just wanted to present a little bit about the key features of the Max Clinic. The references are in my slides if you want to learn more. And there's also a YouTube video here. And with permission of both people in this picture, this is a client of the Max Clinic, a very dear patient of ours, as well as one of our former DIS. Thank you for listening and have a wonderful day.
Great, thanks so much, Meena. So my name is Matt Hickey. I'm a physician with the Pop-Up program in San Francisco. Just wanted to summarize a couple of key points from what we've heard so far. So first, thank you all for listening. Our big motivation for this talk was we wanted to share a couple of examples of care models that are redesigned to try to address challenges that some people experience engaging in usual care. We know there are a number of psychosocial barriers that some people face, including housing instability, substance use, mental health, or stigma, that can make that care challenging. And so we sought to reorganize care delivery for this population. And others are doing similar work, and we wanted to share a couple of key elements that we think are particularly important. So as you heard, I think some key elements of the we have been working on in Pop-Up and Max Clinic are first making care walk-in, so people can walk in and get true primary care, not urgent care where it's just dealing with a one-off issue, but continuity of care through a walk-in model. The other key element that we talked about is the ability to do panel management. So again, this sort of is a part of the low barrier primary care element, but following people over time, being able to follow up results and do coordination with other specialists and people outside of the medical system. And then finally, having a system that integrates social services and case management directly into the model to provide wraparound care. Those are some of the key elements that we found. We recognize also that these are going to look different in different contexts. The second key point I think I just wanted to point out is the importance of partnerships with other services outside of the medical system. So this includes legal services, case management programs, street medicine, jail health, methadone clinics, and others. And I think as you heard, for both Pop-Up and Max, this started small and it took time to build. And so I think as you're thinking about these types of low barrier models in your own settings, it's just important to note that you don't have to have all of this in place right from the beginning. That certainly took us a long time to get some of these partnerships up and running. And then the last point I just want to emphasize that we talked about is the importance of adaptation. So both Pop-Up and Max Clinic started small, had small tests of change and innovated and were able to adapt over time. And I think the others that are doing similar work have had similar experiences. So the elements that we talked about here, we think the ones on this slide are some of the key elements. Some others may look very different in other contexts. I think one example is the walk-in or drop-in care. In some settings, like in Pop-Up and Max, there's dedicated provider time for those drop-in visits. In other settings, it may look more like open access scheduling. So I think that adaptation is a key element. The other thing is adaptation to new opportunities. So both of our programs look different now than they did when they started. A key element for Pop-Up has been adapting to long-acting injectables, which, as you saw from Liz's talk, about a quarter of our patients are on those now. And there have been other adaptations over time. So that's another key element that I wanted to pull out. Just want to thank you all for listening. We hope you learned something about the models that we have been implementing in Seattle and San Francisco, and welcome you to reach out if you have any questions for us.